Good afternoon. Good afternoon. Shall we start the presentation? So today my instruction course is on complications of glaucoma treatment techniques, a discussion based on clinical cases. First, I would like to introduce the speakers. Sir is actually, he has not come. He had a keynote address. We'll go to the next speaker, please. I welcome Ganesh V. Raman sir. He is the head of glaucoma department of Arvind Pondicherry and an expert in all treatment procedures of glaucoma like MIX and SLT. Next, I would like to welcome Smita madam. She is having a lot of experience in glaucoma. She is the professor and having more than 20 years of teaching experience at Thrissur Medical College. I would also like to welcome Dr. Rani Balamurali Krishnan. She, madam, is the medical director and senior consultant at Amardeep Kollam. So first of all, I would like to welcome Dr. Rani Balamurali Krishnan for a talk on complications of drugs in glaucoma.
Good morning all. So I'll be talking on a clinical based discussion on the side effects of glaucoma medication. So this is the classification of the drugs. The adverse reactions can be from the main agent or the preservatives. Drug allergy is the most common important side effect. Brimonidine commonly causes drug allergies and can be delayed for many years. The topical complications are more frequent with prostaglandins and systemic ones are more frequent with beta blockers. Brimonidine is no benign offender. Beta blockers, owing to their affordability and efficacy, they are frequently selected as the initial therapy, either as monotherapy or in combination regimens. So this is the story of a patient who first time was diagnosed glaucoma. He was a famous writer. When I asked the history of bronchial asthma, he denied. But a week later, he brought me the leaflet from the eye drops and told me that it is written in this, you will get bronchial asthma if you use this drug. So some patients, even if they don't have the history, 1 in 50 of the patients can develop an obstructive airway disease, even though they don't have the history of bronchial asthma. Bronchial asthma, there are so many patients who were using beta blockers. When you stop the drug, you can see the improvement in their obstructive airway disease. So when you ask the history of bronchial asthma, you can ask whether they're using a steroid inhaler, because steroids are notorious to produce the exacerbation of the increase in IUP, steroid-induced glaucoma. So even though the inhalers have only topical effect in the bronchial muscles, they still can produce, several studies show that they can also produce raised IUP in especially in advanced cases. You can refer the patient to the pulmonologist for an alternate therapy in advanced glaucoma. This is the story of a cardiac complication that has occurred to an ENT surgeon's wife. She was admitted with recurrent attacks of syncope and was diagnosed as arrhythmia, so necessitating the discontinuation of beta blockers. So you have to assess the pulse before prescribing, and in cases of Raynaud's phenomenon also you have to discontinue beta blockers. Then this was a story of a patient who came for diabetic retinopathy evaluation and was diagnosed glaucoma. She was referred to the physician for diabetic control. He gave history of recurrent attacks of folds. So when I talked, she said she doesn't have any history of tremor or sweating. And when I stopped the beta blockers and she came later, she didn't give any history of hypoglycemia, maybe because the physician has titrated the drug. Then nocturnal hypertension in patients with compromised disc perfusion can also cause constricted fields. So in such cases with advanced glaucoma, if the patient is taking antihypertensives at night, you have to refer the patient to evaluate for nocturnal hypertension and make changes in the drug. It can cause CNS depression, aggression of myasthenia. There can be topical side effects like conjunctival congestion and foreign body sensation. Because of the membrane stabilizing effect, it can cause local anesthesia and reduce reflex tearing and epithelial toxicity. And about the alpha-adrenergic agonist, brimonidine is the commonest one which we use. It can cause allergy ranging from varied grades, including simple itching, hyperemia, severe congestion, and contact dermatitis. This is the story of a woman who came with a history of glaucoma for 2 years. She was on 3 drugs and she was having recurrent attacks of redness, and she was treated with steroids, all sorts of steroids, loteprednol, prednisolone, and systemic steroids. But her IOP was not controlled and she was getting recurrent attacks of redness. So in view of the corkscrew vessels, she was advised a digital subtraction angiography by an ophthalmologist. When I took the history, I came to know that her redness was subsiding when she took steroids. And she never gave a history of itching. So when I stopped brimonidine, a week later, she came with a white eye, and her IOP got controlled in 2-3 weeks' time. So then contact dermatitis is also very common with brimonidine. The picture below is that of a patient who has a hyperpigmentation, thickening of the lids, and when you discontinue that disappears. The picture above is a patient who was on treatment from a dermatologist for his skin condition. That was a steroid ointment. He was also having a contact dermatitis because of brimonidine. When we stopped the drug, the skin condition improved and we could withdraw the steroids, and IOP also got controlled. So when you may get certain cases of follicular conjunctivitis as a complication of brimonidine, so these allergens should be stopped to prevent conjunctival inflammation, because at some cases you may have to take the patient for trabeculectomy. We need a good loose supple conjunctiva for a good blood formation. So there can be other systemic side effects like tiredness and dryness of mouth. These are not very rare, and it is contraindicated in infants and children due to the CNS depression, respiratory arrest, seizures. The risk of hypertensive crisis when given with MAO inhibitors when the patient take that for depression. Then it can cause granulomatous anterior uveitis, and you can prevent the absorption of the drug by closing the lids for 3 minutes. That reduces the absorption by 50%, and lacrimal occlusion enhances it. Epithelial drug toxicity can occur with any of the anti-glaucoma drug, and especially when topical drops with benzalkonium colloid preservative. It is more common with dorzolamide. You can use drugs with preservative-free drugs, or the ones with which are more cornea-friendly preservatives, and can use lubricants, frequent lubricant application. And you can take the patient for surgery if none of the drugs are tolerated. Prostaglandin analogs are notorious to produce hyperemia, bimatoprost more than latanoprost, and then comes the travoprost. Iris hyperpigmentation, blurred vision, skin hyperpigmentation, orbitopathy, exacerbation of keratitis, cystoid macular edema, and hypertrichosis. You can see the picture of a hypertrichosis, and the patient below is having hyperpigmentation as well as hypertrichosis. So when you discontinue the drug, the hyperpigmentation, all this can disappear except the iris hyperpigmentation. So this hyperpigmentation actually happens in the epidermis level. So this epidermis is frequently shed. So renewal happens and you can get lighter colored skin. So this is a case of prostaglandin associated periorbitopathy, where there is upper lid ptosis, deepening of upper eyelid sulcus, periorbital fat atrophy, and mild inophthalmos. You can see the video of the tight lids. When I try to pull, the lids are not, it's difficult to pull the lids, and the eversion is also difficult. Then the systemic side effects can induce uterine contraction and premature labor. The systemic side effects are few with prostaglandins, can sometimes cause flu-like symptoms. It is contraindicated in pregnancy, uveitic glaucoma, immediate postoperative period, and healed or active herpes simplex. Carbonic anhydrase inhibitors, acetosalamide is the one which we use systemically, and it can rarely cause Stevens-Johnson syndrome. This is a case of Stevens-Johnson syndrome. You can see the conjunctival, change of conjunctival architecture, and loss of meibomian glands were also for this patient. Electrolyte imbalances is commonly hypokalemia. It can cause metabolic acidosis, paresthesia, urolithiasis, blood dyscrasias, fatigue, malaise, sickling, and sickle cell crisis in those with sickle cell anemia. It can cause choroidal effusion and angle closure glaucoma also. Contraindicated in respiratory acidosis, renal disease, kidney stones, pregnancy, and liver disease. It should be used in caution with corneal endothelial disease, as corneal endothelium also has carbonic anhydrase. And its role is, the risk of reaction with acetosalamide in a patient with sulfonamide allergy is low, and many studies show that it is not there is no such risk now. However, acetazolamide is listed as possibly cross-reacting with sulfonamide drug in the drug information and the package insert. The parasymptomimetic drugs which we use commonly is pilocarpine, and this is the story of a gynecologist who called me one day telling that I'm having vitreous floaters. I told her to come for a dilated indirect ophthalmoscopy next day. So when I came to the OP, she had already got her eyes dilated. So when I examined, the anterior chamber was shallow and there was a closed angle. Her IOP was 28 and she was in a hurry, so I gave Diamox and pilocarpine and Timolol. And she said, I'll come in the evening, and she didn't turn up. At night, she called me and told that I'm having severe headache. I didn't know whether it was due to an angle closure or brow ache. She was telling that it was more of a brow ache. So I told her, you take 2 tablets of Diamox and pilocarpine. But next day morning, she came with a white eye, and she said, I took only mefenamic acid. And probably that could be a ciliary spasm. The other side effects include induced myopia, posterior synecdoche, miosis, constricted fields, cataract, retinal tear, retinal detachment, paradoxical glaucoma due to anterior shift of iris lens diaphragm, iris cysts. And it should be avoided in uveitic glaucoma. And rare systemic side effects include sweating, increased salivation, and lacrimation. So rho kinase inhibitors, the commonly used ones are ripasudil and netazudil. Both can cause hyperemia and subconjunctival hemorrhages. And netazudil is notorious to produce vortex keratopathy and ripasudil blepharitis. Hyperosmotic agents, the one which we commonly use is mannitol. It can cause congestive cardiac failure due to increased blood volume, urinary retention, electrolyte disturbances, and myocardial infarction. In pregnancy and lactating mothers, this is a chart which shows the FDA drug risk categories in pregnancy. All the anti-glaucoma medications are category C except brimonidine and dipivefrin, which are category B. So, and it should be brimonidine category B should be avoided in nursing mothers but can be used in pregnancy. Beta blockers concentrate 5-fold in breast milk, so should be avoided in breastfeeding children. Prostaglandins can cause uterine contraction and premature labor. In pediatric glaucoma, the drugs available are beta blockers, carbonic anhydrase inhibitors, and alpha-2 agonists and prostaglandin analogues. Alpha-2 agonists have severe adverse side effects in children and contraindicate for those younger than 2 years. Latanoprost is less effective in lowering IOP in children than in adults. So in conclusion, these adverse effects can be minimized when they are detected early, prevented by reducing the number of different eye drops used via fixed combination eye drops, reducing the number of times the eye drops are administered, using benzalkonium chloride-free eye drops, using lower concentration of eye drops, and providing proper drop installation training, educate about adverse effects. Thank you.
Thank you, Rani Madam, for that wonderful talk. Now I would like to invite Professor Dr. J.S. Balla. Sir is the Senior Consultant, Professor and Academic in charge of DDU, New Delhi, and he has 28 years of teaching experience. He would be giving the keynote address on bleb leak identification and management.
Thank you. Again, I'm thankful to the KSOS for giving me this opportunity. The topic I am going to cover is identification and management of bleb leaks. The incidence of post-operative bleb leak after TRAB ranges from 0 to 56%. It can be both early and late, and the late leakage is about 3 to almost 13%. Early bleb leak occurs in the early post-op period after glaucoma filtering surgery, and it is usually due to the surgical trauma to the conjunctiva or inadequate conjunctival closure, and it can be avoided by careful and meticulous surgical technique. And the late bleb leak occurs months to years later, and it is usually following adjunctive use of the antimetabolites. Bleb leaks can be high flow leaks that are CDL positive, or they can be low flow leaks that may present with just bleb sweating or transconjunctival ooze. And late bleb leaks are more commonly seen with cystic avascular blebs compared to the thick-walled blebs. So these are some of the terms that are commonly used in the publications. Leaking bleb is presence of positive CDL test, that is fluorescein dye being washed away by the aqueous. And sweating bleb is increase in the fluorescence of the bleb area with no obvious aqueous streaming on the Seidel test. And there is no conjunctival defect in the sweating bleb, but it had either staining or slow ooze of aqueous with hypotony. Hypotony we label with IOP less than 5 millimeter mercury on more than 2 occasions, and hypotenuse maculopathy is loss of more than 2 or more than 2 lines plus presence of the macular folds. So what are the complications associated with bleb leak? It can lead to hypotenuse maculopathy, choroidal detachment, shallow or flat anterior chamber, and then corneal anterior segment complication like corneal decompensation, cataract formation. This leads to increased risk. It is a risk factor for bleb failure, and these blebs are more prone to blebitis and bleb-related endophthalmitis. So how can we prevent the wound leaks? One is smaller conjunctival incision in both the fornix and limbus-based conjunctival flaps, prevention of conjunctival tears and buttonholes by minimal tissue handling, and in fornix-based flap, we should do meticulous watertight wound closure. May include Tennant's layer in the closure, and the corneal conjunctival closure is done also, which can prevent the wound leak in fornix-based flap. In limbus-based flap, we should place the conjunctival incision as posteriorly as possible, and we should do careful conjunctival edge protection during mitomycin C use and use of the round body, not non-crushing conjunctival clamp. And what are the treatment options available for bleb leaks? Medical is in the form of antibiotics, cycloplegics. We can use bandage contact lens, or the Simmons shell can be used. And surgical is by conjunctival resuturing or bleb repair with conjunctival advancements or conjunctival autograft, depending on the size of the conjunctival defects. So these are some of the surgical procedures. We can either use Tennant's capsule is sutured into the buttonhole as seen on the left first slide, or we can use the 10-0 nylon mattress suture to close this buttonholing, or tear in the conjunctiva at the limbus can be closed by making a small corneal groove, and then we can suture the conjunctiva to this groove. We need to differentiate ischemic bleb from blebitis. See, blebitis presents with ischemic conjunctiva and surrounding conjunctival and ciliary congestion, most intense around the bleb edge, whereas when it is associated with purulent discharge, chemosis, and anterior chamber reaction like KPs and hypopion, then it becomes blebitis. So what are the conservative measures? I'll again reinforce. These are antibiotics, cycloplegics, pressure patching, bandage contact lens, collagen shields, glaucoma shell, Simmons shell tamponade. We can use aqueous suppressants, bleb needle redirection, laser application to the bleb, autologous blood injection has been done, and also the use of cyanoacrylate tissue glue. Collagen cross-linking has also been used as one of the procedures, where it is a non-invasive treatment offering reasonable success rate for filtering bleb leakage, and we may not require invasive surgical bleb revisions. There is also role of oral doxycycline and large diameter bandage contact lens. Oral doxycycline, by inducing inflammation, and anti-metallum MMP can really help in the treatment of bleb leaks. So what are the surgical choices? Surgical choices are these as listed here: conjunctival advancements or conjunctival autologous conjunctival patch grafting, amniotic membrane transplantation, scleral patch graft, corneal patch graft, even the facial autograft has been used, bleb needle redirection, and bleb plication as also is one of the procedures. So choice of surgical repair depends on the size and site. Conjunctival advancement is preferred in presence of small avascular bleb or small anterior leak, which is usually less than 3 millimeter from the limbus, the surrounding healthy and mobile conjunctiva. An autograft is used in the presence of large avascular bleb or a small bleb with surrounding scarred conjunctiva. Excision is done if the bleb wall is ischemic and unhealthy, and then the whole bleb is excised. So indications for bleb repair are bleb dysesthesia, large sweating bleb, or bleb leak or blebitis. So in summary, bleb leak with no hypotony or significant anterior chamber shallowing, we can use bandage contact lens. Bleb leak or leak associated with AC shallowing, choroidals or hypotony, surgical repair of the leak is done. And we can also use aqueous suppressants like oral acetazolamide. Topical steroids are reduced, And if a conservative approach fails to solve the bleb leak, then we may have to use interventional approach like conjunctival enhancement or conjunctival autograft. I'll also take this opportunity to request all of you for supporting my candidature for Joint Secretary AIOS in the coming online election. Thank you everyone for your kind and patient hearing.
Thank you. Thank you, sir. Now I request Dr. Veena Vishwam, who is a consultant glaucoma and cataract surgeon at Amardeep Hospitals, to tell us about give us a case-based discussion on complications of glaucoma laser treatment. Dr. Veena.
Good afternoon, everyone. Thank you, madam. My presentation is on laser complications in glaucoma. My experience of lasers in glaucoma is peripheral iridotomy and selective laser trabeculoplasty. Peripheral iridotomy, most of you will be familiar with the common complications. Transient IOP rise is very common. I am not going to take a case and present it before you. So maybe because of AC bleeding or iritis, IOP hike is very common in after PI. Then thick iris may need multiple shots. Spontaneous closure is common. Endothelial burns because the anterior chamber will be shallow. Endothelial burns may also occur. Hyphema is common because it is a photodisruptive laser. Anticoagulants, whether to stop or not, is your discretion. You may decide, depend upon the condition of the patient. Then what I do is I use an Abraham lens, 66 diopters, iridotomy lens, focus and separate and aim a little deeper into the iris trauma and give the shot, and I give a tamponade in case there is a bleeding. Then I choose also as everyone, I choose the iris crypts. Then lens capsule damage is common, cataract formation and posterior synecdoche at the site of PI. All these are commonly seen and usually often noticed after pupil dilation. Then if the PI is large, as in this case, this was a very resistant pupil, iris, and we had to give multiple shots. The PI was closing again and again, so the PI has come very large. So in such conditions, zonular damage may occur, and some cases of even subline subluxation are also reported. CME may occur because of repeated laser applications. Then late complications like closure or peripheral anterior synecdoche, decreased endothelial cell counts again. Then pilocarpine use in long term may result in RD. All these are rare complications. Dysphotopsia, as you all know, if the superior area is chosen, I do not usually choose the superior area because it may interfere with the tear meniscus and may cause diplopia. Usually my preferred site is temporal PI, and I don't usually get dysphotopsia or diplopia in any of my patients. Then I am discussing three rare cases, important cases after PI and one after selective laser trabeculoplasty complications which I got. So this is case number 1. It was a 56-year-old lady who was a hypertensive, and her mother had history of glaucoma. Her visual acuity was 612 both eyes. She had a +1 diopter sphere with 6/6 vision in both eyes, IMSC both eyes. Anterior chamber depth was Van Herrick's 2. Schafer's grade 0 right eye, slit angle left eye. CDR was 0.6 and 0.4. IOP was 28 and 24. So laser PI was done in both eyes. Post PI day 1, IOP was 22 and 24 and 24 in right eye and 22 in left eye. We gave timolol and predfort as usual, but she came 1 week later with severe pain, vomiting and headache. As you all know, the vision the complication I'll tell later. The vision had dropped to CF. And left eye vision was 612. She had circumcorneal congestion, cornea was hazy, AC was flat, pupil mid dilated, periphery touching pupil, touching iris, PI was patent. So IOP was 60. So the most common suggestion is that of a malignant glaucoma. Okay, so we gave atropine, IV mannitol, timolol, dorzolamide and brimonidine and topical steroids. IOP came down to 26. But even after 1 week, the IOP is remaining 26, AC is still shallow, and we are planning a cataract extraction in that case. The case number 2 was a 52-year-old male. Visual acuity 6/6 both eyes, anterior segment NS1, AAC, Van Herrick's 2, Schaffer's grade 0 to 1, CDR 0.8 in both eyes, but as you can see, the OCT is coming as normal. IOP was 50 in the right eye and 38 in the left eye. Laser PI was done in both eyes. He needed repeated shots. The picture which I showed earlier was that of the patient. He needed repeated shots. Every time we did it, it was closing, and he had severe iritis. 2 weeks later, but the IOP luckily came down to 16 in both eyes. IOP 1 month later was increasing to 26, and he developed a correctopia. Gonio showed peripheral anterior synechiae in both eyes. 2 quadrants were open, but it was becoming shallow. And lens thickness we did, and it was around 4.8 millimeters. So is it a combined mechanism, or is it because of my laser shots damaging his zonules? Is it coming forward, or is it because of the lens thickness? He is currently on anti-glaucoma medications. This is the anterior segment OCT of the patient. And because the vision is 6/6, we did not do a cataract surgery. We did not advise a cataract surgery in that patient, but still we are planning to go ahead with a cataract surgery in the recent future. Now the case number 3 was a 48-year-old female with family history of glaucoma, visual acuity 6/6 both eyes, AC Van Herrick 2, gonio, grade 1 Schaffer's, CDR 0.7, IOP 26 right eye, 22 left eye, visual field normal, OCT normal, PACI 542 and 548, thick iris, repeated PI, non-patent PI, we repeated grade 3 cells and pigments. IOP was again 32 and 34, we treated with steroids. So every time we repeated the PI, we had to treat her with steroids. And 3 weeks post-laser, PI was patent, but IOP was remaining at 40. So though the cornea became clear, AC became deep, occasional cells were there, till steroids tapered, endothelial cells showed fine KPs because of the reaction. Again, sometimes the cells were coming, steroid were stepped up and reduced. Now this IOP after 6 months is still in the 30s, and we are putting her on anti-glaucoma medication. So steroid response, she might be a steroid responder. So that is another complication. When you repeatedly treat the patient after PI with steroids, the patient may go in for a, please check whether the IOP is coming up even after the PI is patent and AC has been quiet. Now, I have one more case. This is a usually we know that in selective laser trabeculoplasty, we are not doing any damage to the trabecular meshwork as such. Only the melanocytes are being treated, and complication rates are much lesser with selective laser trabeculoplasty. Now, I had a case like this. I would like to get the opinion of the experts as well. This was a 64-year-old male, one-eyed patient with history of bronchial asthma, allergy to brimonidine, visual acuity, right eye was hand movements, left eye 612, IMSC, pupil sluggish, RAPD in the left eye, CDR is 0.5 in the right eye, NRR normal in right eye, the eye with low vision, and in the left eye which had glaucoma, CDR is 0.9 and near total cupping. Right eye had retinal geographic atrophy, but disc was fairly normal. Left eye was the advanced glaucoma eye. So the right eye IOP is 17, left eye 20. He was already on travoprost and dorzolamide. He was allergic to ROCK inhibitors and not willing for trabeculectomy. So because the patient's IOP was remaining on the higher range and it was the field was advancing, we did not have any other option. So after discussing with experts, we thought of going in for a selective laser trabeculoplasty and trying it for the patient. And to our despair, the IOP increased to 26 after this. I even discussed this case with Ganesh sir in the last CME, I think, and According to him also, it is better to restrain from doing SLT in advanced glaucoma patients. But to our relief, after 8 months, the IOP is now 12 in the left eye. So how did it come down drastically after this? Is there a delayed response for SLT? Is something I would like to get an explanation from the experts as well. Thank you. That's my presentation. Thanks.
Thank you, Veena. Would you like to speak now, sir?
Yeah, delayed response is known. I mean, even for a primary SLT in a mild to moderate, you can get a response in about 4 to 5 months also. So you just handhold the patients for some time. And was the patient on medication at 8 months? He was still on medication? Not steroids for the SLT. Yes, that's understandable. But the glaucoma medications were continued. So the same dorzolamide and travoprost was being continued. Now it's, yeah, so you could get a delayed response with SLT. So even the light trial, they have done good number of eyes with have advanced glaucoma. They have shown good results. Unfortunately, in that same proportion of patients, same group of patients, some of them have gone on to undergo surgery. So they do respond in advanced glaucoma, but we should, it's very difficult to predict who will respond and who will go in for surgery. So no harm in doing it, provided we can buy some time and sensitize the patient that the need for surgery is there, and then go in for surgery at a later date, if necessary.
Next speaker is Dr. Smita Narayanan. Madam is a professor at Thrissur Medical College, and she has more than 20 years of teaching experience. Madam's topic is on complications of trabeculectomy.
Good morning, ladies. Good afternoon, ladies and gentlemen. I shall be speaking about some of the complications of trabeculectomy. Basically, a filtration surgery is a trade-off between efficacy and safety. So the more your surgery is able to control the intraocular pressure, the less likely is that it would be safe. That is, the chances of having a complication are higher, and that is why even perfect trabs create ongoing worries. You still have worries even if your intraocular pressure is controlled for, say, more than a year. You still are worried whether there would be an adverse effect later on or not. So today I'm going to describe these complications into 3 groups. The first is the most dreaded complications, which not only you as an ophthalmic surgeon would find it difficult to manage, you will need the services of a vitreoretinal surgeon. And secondly, even after getting the services of vitreoretinal surgeon, the prognosis would not be great. The second group is those which are slightly less dreaded, but you will not need the services of a vitreoretinal surgeon. You as an ophthalmic surgeon are most likely able to manage that, but again, the prognosis in most of them is not great. And then the third group is the irritating complications, where the patient is always going to be behind you, but those are things which can be managed. So let us look at this patient. This was a patient who came after a small incision cataract surgery with severe pain and blurred vision. On examination, there was, not in this picture, but there was a uniformly shallow anterior chamber with an intraocular pressure in the late 20s. This patient had a patent iridectomy, and when a UBM is performed in such a patient, you can see iridocorneal touch. Most of the times, the risk factors are a preoperative high intraocular pressure, sudden shallowing of the anterior chamber intraoperatively, or history of aqueous misdirection syndrome in the other eye. This patient was medically managed with cycloplegics and topical steroids and aqueous suppressants along with intravenous mannitol. You can also perform an argon laser shrinkage of the ciliary process through the large iridectomy, or most importantly, you can do an anterior hyaloidotomy if the patient is pseudophakic or aphakic. But the most definitive management is to make the eye unicameral, meaning that the anterior chamber and the posterior chamber become one. So that is by doing an irido-zonulo-hyaloidovitrectomy. wherein you can see this video with the patient with the flat anterior chamber. And here, first, a vitrectomy port is done. First, a vitrectomy port is made and a small vitrectomy is performed so that the anterior chamber is deepened. After that, when the anterior chamber has deepened, you can perform your phacoemulsification and implant the intraocular lens. Then again you go back to your vitrectomy port and then perform a small core vitrectomy and direct your vitrectomy port anteriorly to perform a hyaloidotomy. You can use iris hooks to visualize the periphery of the lens capsule and perform an anterior and posterior opening on the anterior capsule, and then come again into the anterior chamber and perform a iridectomy. So now you have a continuous communication between the anterior and posterior chamber, and in this patient the intraocular pressure was managed. The second instance is of a patient who was 78 years old, who had a trabeculectomy done 2 weeks back and came with sudden excruciating pain in the eye with sudden loss of vision. And on examination, the eye was shallow with stony hard and was stony hard. So usually such patients present into the casualty after some amount of straining or a sort of Valsalva maneuver, like say they are going and straining in the toilet or sneezing or coughing, or they are trying to reach for something and then they're holding their breath. So on the B scan, you can see this heterogeneous echoes, which are indicative of the presence of blood in the vitreous cavity. Intraoperatively, it can be identified as a change in the red reflex. You can see a shadow moving across the pupil, and then the iris and the vitreous try to come out of all the incisions that you have made. Eye is stony hard with a shallow anterior chamber. So this usually happens when there is a sudden decompression or hypotony during surgery in elderly patients with uncontrolled systemic hypertension. So this has to be managed by a vitreoretinal surgeon. Usually you have to perform serial ultrasounds to look for clot lysis, and at that time the patient will have severe pain in the eye, so you have to give opioid analgesics to manage that pain. So after adequate clot lysis has occurred, you can plan a surgical removal of that straw-colored fluid, and that can be done by doing an ultrasound B scan to find out the highest area of elevation where you can do a sclerotomy. And then most importantly, you have to keep an anterior chamber maintainer, otherwise this is a vicious cycle which can keep on recurring. So once that anterior chamber maintainer is there, you have to press with the bud to milk out all the straw-colored fluid. A wipeout phenomena, nowadays we do not usually say wipeout phenomena because we know most of the causes which can lead to wipeout, but it is the sudden idiopathic, irreversible loss of central vision seen in people with split fixation or severe hypotony. You can see the split fixation here. And the last condition which is very terrifying is the blebitis or other manifestations leading to anterior chamber inflammation or endophthalmitis. So you have this typical white on red sign in the eye, in the bleb area, and when you do a B scan you will see low to moderate echoes which are like clumps which tell you about the, and in this case you can also see that there is a very shallow retinal detachment. Mostly it is associated with mitomycin C used for a longer duration of time. And now it has been said that instead of mitomycin C, chronic blepharitis is the most important risk factor. It may also be associated with bleb leaks which have not been attended to. So for every trabeculectomy patient, you have to give us specific advice to avoid splashing water into the eyes and use a protective shield during sleep, or use protective goggles or avoid swimming. Should not use antibiotic eye drops for a long time, and steroid drops, though they have to be used, they should be under the supervision of the ophthalmologist. And most importantly, you should warn about early signs of blebitis and endophthalmitis. Now there are other complications. Bleb leak has already been discussed. You can see this robust bleb leak which happened after few days on the first or second post-op day. So the most important thing about bleb leaks is you should prevent it on the table itself. You should not let a bleb leak happen, though it happens, but it is best to prevent it on the table itself. So you can apply a purse string, you can do a patching or a conjunctival aqueous suppressants. The large bandage contact lens, the 16 mm bandage contact lens are a great idea. In the late stages after trabeculectomy, you can have a sweating bleb, and I have found that autologous blood is a good idea. In the management, you can inject blood and that can cause some fibrosis. Free conjunctival graft can also be done. It is important that we suture the bleb with the 2 wing sutures at the edges, but sometimes if the conjunctiva is loose in between, you may have to put in a suture in between so that the bleb does not retract. Choroidal detachments happen with most of the trabeculectomy. When you are giving these topical antibiotics, most of the times that is managed well, but sometimes the choroidal detachment can lead to hypotony. So again, you may have to give systemic steroids. What is important is that you should prevent this kissing choroidal formation, because that means the patient will lose vision. You can anticipate that the patient may have choroidal effusions in patients with nanophthalmos, where you can make a sclerotomy preoperatively, which is very helpful in the management. The next instance is about hypotenuse maculopathy. So basically this is more a problem with the sclera, where the sclera has either melted or the sutures have given way. So you can use the adjacent sclera, where this is a video where we have used the dissected partial thickness adjacent sclera and then turned it over and then sutured it over the bleb. You can also, this can cause hypotenuse maculopathy, and if the folds become permanent, then the vision loss can happen. It is very difficult to calculate the intraocular lens power in a patient with hypotenuse maculopathy. Then in the case of an overfiltering bleb, you can place the Palmberg sutures, which are sutures from the conjunctival end of the bleb, placed much more posteriorly into the sclera. These are 9-0 or 10-0 nylon sutures, which are placed tight. And as weeks progress, the sutures get buried into the bleb and the bleb gets localized. And so you don't have to actually take out the sutures, and so there is a sort of reversal of hypotony with this. Bleb failure actually is a very big topic. I'm not going to discuss everything about it. The subconjunctival or episcleral fibrosis has an incidence of about 20% in the early post-op period and 30 to 50% in the late post-op period. You may have to consider the management depending upon the stages of the healing of the bleb. Like in the inflammation, in the early inflammatory stage, you may have to increase the number of topical number of times you're putting topical steroids. In the proliferative phase, you may have to go for suture lysis or a digital massage, and in the late stages, you may have to go for needling or even a bleb revision. Among the lesser complications is the bleb dysesthesia, and this is a video given to me by Dr. John Davis Akra. You can see a small bubble coming out every time the patient blinks, and that is a very irritating complication for the patient. You can see this bubble at the edge of the lid. So such a thing can be associated, this dysesthesia can be associated with a click, an audible click, which the patient finds it very irritating. This can also be associated with a Delin, where there is no wetting of the cornea adjacent to the bleb. Then you can have this overhanging bleb, which is like you are using mitomycin in 4 different patients, and all the 4 will have 4 different kinds of bleb. And this overhanging bleb, it's cosmetically not very great to look at. You can just dissect the bleb from the surface of the cornea using a visco cannula and then cut it off. Most of the time it works very well. Maybe you may have to use a suture. I have tried to describe many of the complications. Still there are many. These are my references. Thanks to Dr. Jayaprasad, Dr. Sunita Dubey, thank you, and John. Thank you very much for your kind attention.
Thank you, Smita Madam, for that very useful talk. Now, I would like to invite our next speaker, Dr. Ganesh V. Raman sir. He is the head of glaucoma department at Aravind, Coimbatore. Sir will speak to us on complications of mix in glaucoma.
Thank you, Dr. Veena. Thank you, Chairman of the Scientific Committee KSOS, for having me here, providing me this opportunity. I'm going to speak to you on complications of MIGS. MIGS, as you know, there are numerous devices which are available. Some are proprietary and some are developed by innovative surgeons. And in India, we have the excisional MIGS, which are very common. And that's the main thing which we are going to talk about. And the excisional MIGS include the KDB, the Bang, the GAT, the iStent is the implantable mix. And these are the selection of mixed procedure which you could, work around. And most of the common complications which people perceive or come about as raised intraocular pressure, that's something which happens paradoxically in mix. And shallow anterior chamber, hyphema, cyclodialysis, cleft because the approach is not appropriate, past formation, corneal decompensation, late bleeding, and failed mix procedures, or including failed GAT. So iris prolapse is something which happens during surgery, mainly because you have a tendency to use a larger incision. So the way to come about this is to use a smaller incision, 2.2, and the side port should be made more towards the nasal angle if you're performing a GAT procedure or something like that. So instead of towards the 6 o'clock or 12 o'clock. And also during anesthesia, avoid a large volume block. You have a severe positive pressure and the iris will tend to prolapse. The issue is with if you don't have a 2.2, if you have to use a 2.8, you can always use a side port for your main wound entries. You put a port parallel adjacent to the main wound and then do your procedures through that. For example, a tanito. The other aspect is you can suture that wound and go between the sutures to perform your procedure. Lens touch is it's not very common if you are doing mix in which you are not tackling the cataract. We perform this in juvenile glaucomas and POAGs. We perform on patients with allergy to the medications. We perform a GAT procedure. So be very careful when you're introducing the instrument. If you're doing a GAT or a tanitos, be very careful. And when you're taking out the suture, that's when the problem happens. You have a tendency for the suture to sort of touch and can you play the video? I think it was formatted. Yeah, can you forward it? Yeah, and this stage, this is when the touch sort of happens. When you flip it out, so be very careful, you rotate it and then take out the suture gently. Make sure it goes over the iris rather than over the lens. Cyclodialysis and iridosis is quite common, not very common, but when they happen, they add to the low intraocular pressure. So you assume that your mix has actually worked. So you could be, the corollary to that, the visual acuity will not be so good because you'll have extremely low vision. So if you've done a good mix and you got a low IOP, but the vision is not so good, just do a repeat gonio and see whether you have created some cyclodialysis. This also happens when you have a large lens vault to tackle within POAG itself. Sometimes POAG eyes will have a large lens vault and you've gone across and then done the procedure, but the view is not so good, so you've nicked some areas of the ciliary processes. So this has happened to me once. So while doing the cataract surgery, I did the cyclodialysis repair. So I got away by doing that. You get profound hyper. The other thing is raised IOP. So because of using intensive steroids, you could get raised intraocular pressure. The logic here is to use short pulse dose therapy. So we use steroid only for 10 days after any mixed procedure. If you use a lot of steroids, the inner wall is what you have ripped off. The outer wall still remains. And I presume, I'm not sure, the outer wall can also respond to steroid. So you pump it with steroids, the outer wall will respond to steroid and it will cause the collector channels to get blocked. You will get a paralysis. So many people think that it's because of the retained viscoelastic which you have left in place, but actually it may not be so. You would have done a lot of effort to remove that, but you still get a... So if you're doing extensive mix like GAT, better to leave sodium hyaluronate in the chamber. That doesn't cause raised IOP, but you must not overfill it. If you happen to overfill it in the evening, you can always burp the wound. So once you burp the wound with antibiotics or povidone iodine application, then you reduce the intraocular pressure quickly. So why we say that to do that is because you immediately have a shallow chamber if you don't, after GAT, if you sort of, and you also get a chamber filled with blood. So these are two things which happen, which we'll discuss subsequently. So the logic of leaving sodium halide in the antechamber. Past formation, another reason which can happen for raised IVB, that's because of the flow is excessive. So iris goes and sticks to the cut area, and that causes, so immediately you may have to go back in and remove the pass. Then the mix starts working again, especially GAT or tinnitus. This is a patient who had a silicone oil glaucoma. He had a RKs. You can see the RK cuts there. And first post-op day, the IOP was 9 after GAT with phaco. But about 20 days, he came back with 45 millimeters of mercury. So the important thing is to monitor the pressure very carefully. Don't use the NCT or the iCare tonometer. Look at and this was before the time when we used less steroids. We were pumping him a lot of steroids. So he was still on tapering steroids. And this is how his disc on the right and left eye looked. And you can see that this is where we did the surgery. And about almost 1.5 years, his visual field started dropping. So you have to be very careful that you monitor the intraocular pressure closely after you've done MIGS. So he went off to Dubai and then came back. By the time he had lost significant amount of vision. So shallowing of the chambers usually occurs if you have done extensive cuts, especially tinnitus and GAT. And this happens because of the supraciliary effusion and forward rotation of lens iris diaphragm. And also the anti-glaucoma medications being used and the TMs gets opened up. So this is a patient, and this was a publication in 2020. And after this, we've been looking out for it. So this is a normal angle of a normal patient. It's not even a patient, it's one of our staff. You can see the Schlem's canal, small Schlem's canal area here. And this is the normal angle which looks of a normal 20-year-old lady. Here if you find there is supraciliary effusion 1 day after. So the doctor who did the procedure came to me and said, I got 2 patients, both are angle closure and both have shallow chamber, slight shallow chamber, not very significant, but slight. I said immediately do a ASOCT. When the publication was published, they did a UBM. So we cannot take our patients to do UBM for that. It's quite cumbersome. So since we have the ASOCT, we found that they have supraciliary fluid collection here. So this can happen if you have done extensive cuts. So be very, very careful, and you'll find slight forward rotation of the lens iris diaphragm, and they'll have a slight shallow chamber. The thing is that you should understand this, but not change any protocol. This is resolved on its own as you continue with the treatment. So you shouldn't be definitely you shouldn't put atropine and try to resolve this condition. You just follow the protocol and of the steroids and NSAIDs and whatever, it will resolve on its own. If you put atropine, the pupil will dilate significantly, you get Urach-Zavalia syndrome. The mid-dilated pupil, because you have given extensive cuts, immediately go in for a mid-dilated pupil. So be very careful with treating this condition very aggressively. So this is the other patient who had a similar, and you can see in the corner you have supraciliary fluid collection here. And this is the other eye of the patient, other angle. So this shows quite significant space between the cilia. So this is different from a cyclodialysis cleft because there's no continuity. There's no continuity of the antechamber into the supraciliary space. And corneal decompensation can happen. So this is a patient who had a localized corneal decompensation. He had PPMD, and then his this particular region started decompensating. So we were awaiting a EK for this. Bleeding into the antechamber is quite common, so as you do the surgery, be careful. So use the reverse Trendelenburg position. Keep the eye always pressurized. Raise the intraocular pressure as you're performing the surgery, and try to do a surgery very quickly because blood will continue to come. And if you're doing an extensive mix, like especially a GAT procedure, make sure that you use sodium halide about 40 to 50% fill. And this is the incision I was talking about. Put it more towards the nasal side so that you have access to the nasal area easily, instead of putting it in the 6 o'clock and 12 o'clock position and trying to access the nasal area if you're doing a GAT procedure. Yeah, bleeding. And then hyphema can occur later, especially with hypertensive patients, cardiac patients. And if you don't leave 40% fill of sodium halide, you will definitely get hyphema, especially if you were to do a GAT procedure. So this is how a hyphema will look on day 1, and it will resolve on its own. But we don't, very comfortable leaving hyphema. The main rationale for this is not allowing hyphema to come or leaving orogel in the eye. No financial interest is that the collector channels have actually not experienced any heme. throughout the life till you do this procedure, they have not actually experienced any heme. Now heme, as it gets 1 or 2 days for it to clear, this red RBCs change the morphology, and as they go through the collector channel, they will definitely damage the channels. So late failure can be attributed to foreign material going through the collector channels. So we have to be very, very careful. Whereas one of the reasons for glaucoma is loss of hyaluronic acid in the Schramm's canal. So if you replace it with the artificial one, you have a tendency for it to sort of disintegrate and go along with the aqueous humor into the collector channels and continue to work without causing damage. So flushing the collector channels and allowing heme to enter the collector channels is a strict no-no, so that you continue to have long-term effect of the mixed procedures. And if you have blood, be very careful, that can always go behind the IOL. So this is a patient who was very unhappy. The other eye had undergone trap phaco and he wanted the same sort of outcome. So within a month, we had to do a YAG capsulotomy. You can see here the blood trickling down, and we had to open up the PC within a month, which is actually quite dangerous within a month if you were supposed to do. But we had to do it because of his, he was very keen on regaining his visual acuity. So this is how it looks if you were to leave blood in orogel in the eye. This is the image on your left side is actually the same procedure, GAT, being done 1 year back. This is 1 year outcome, and this is POD1, day 1 outcome. So if you were to leave 40, 50, 60% fill of orogel, you get blood clots and you will get orogel. But the thing is, the intraocular pressure will be pretty low. It won't be very high unless you overfill it. You can always burp the wound if the intraocular pressure is high. You can reduce the pressure in the evening, and then the patient can be comfortable. If there is no discomfort, you can just leave it. It will dissolve by day 10. So iris plus I already mentioned, use a larger section, and always place the section towards the area where you are addressing it. So case selection is very, very important in mix. Always offer mix in mild to moderate glaucoma. Perform an uneventful cataract surgery. Avoid excessive manipulation or to reduce iris pigment dispersion. Deepen the chamber and flatten the iris against the PCIOL in the back so that you don't have blood in the antechamber. If you're doing extensive mix like GAT, leave sodium hyaluronate in the antechamber. Limited mix, there is no real need to lead OVD in the chamber. And beware of fluctuating IOP and systemic anticoagulants the patient may be taking. Uncontrolled hypertension can cause late bleeding, and patient may report to you with reduced vision. I'll stop here. Any questions, I'll be happy to take. Thank you very much.
Thank you, sir. The talk was very informative. Any doubts from the audience?
We had a patient who was operated elsewhere with gas, and the patient came to us, say, about 3 months later. He's one-eyed, and he woke up with midnight wanted to go to the toilet, and he found that he has a blurred vision.
Blurred vision, true,
Yeah.
true.
So he came with, and everyone thought of a vascular occlusion, even me. But when he has gone to the nearby hospital, and they had given him Diamox. So corneal edema was the cause, I think, at that point of time. But when he came to us, he had a clear AC. There were not a trace of RBCs or anything. But a gonioclish, the diagnosis, that at the cleft you could see the NBA-like picture, like
Blood, yeah,
strands.
yeah.
So how late can
Yeah, so this is a monocular patient who is hypertensive, I presume.
He's hypertensive.
He's
yes.
hypertensive.
And he's also into yogasans and all that.
Yeah, so what happens if you have diabetes? We have patients who have undergone GAT and diabetes. When the sugar level increases, you can see blood in the cleft area. So I don't know. I think it's something to do with the vasculature, which causes engorgement of the vessels behind in the orbital area. So the flow gets restricted for some reason. And then you start seeing the vessels. Once you reduce the systemic parameters, like improve the diabetes, those vessels sort of disappear. So this could be something like he might have a bleed, which cleared very quickly and raised the intraocular pressure because the blood cannot go any other way. And then slowly he sort of recovered. So you saw him in the recovery phase. Yeah, and he could have bled. If he's standing something, if he's doing something head-down position, he definitely would have had a hyphema. So late hyphema, especially in pseudo-exfoliation patients, is very common. So we are careful about whom we do extensive mix in, like GAT and all. The limited ones don't cause this problem. KDB, we had a patient who did not take his tablet for some days. He had raised pressure. He immediately came with hyphema. Then we sort of told him that his tablets may not have been working. and then he had to go in for a change of medication. So fluctuating hypertension is another reason. Okay.
I had a very interesting case. This is one lady in whom I did GAT. That was in 2019, one night. So that was before the COVID period, and then she did well. Pressures were in the 11, 12 range. And then she came about 6 months back. Her complaint was transient blurring of vision, 2 episodes. So AC was quite nothing, pressure was, when she came, was normal. And then I sent her for a neuro-ophthalmic evaluation after fees and all, and then they said nothing wrong from that side. Then she came back again with blurring of vision this time. At the time of presentation, she had blurring of vision. This time we saw there was blood in the ankle on gonioscopy.
Yeah.
Then we went into finding out as to her history of medications. So none of these anticoagulants or antiplatelet drugs were there for her. But she has started some medications for her varicose veins from the Ayurvedic physician. And to my surprise, I saw she was on 4 medications. And 3 medicines, I went into finding out what exactly these medicines were. So I found out the contents, and I found out that 3 of them were having anticoagulant properties. So it is very important, a trap or whether you do a GAT or bang, you have to
check the medication
before surgery. I think we should do. Another thing I wanted to ask you is, many a time what happens is during your procedure, head and elevated, you pump hyaluronic acid into the anterior chamber to keep it very tight. Those things and all we do, but still we get hyphema during surgery, intraoperative.
During surgery.
What do you do basically?
Most of the hyphema, if you see, it comes behind the pupil, behind the iris. Have you noticed it? It won't come from the angle. It will keep coming. If you look at it, it will come from the mid area.
You mean from the pupil?
From the pupil to the front. It will keep
the posterior chamber.
Posterior chamber. So when you give your GAT, you are giving shearing stress. The cerebral body is very close by. So that will bleed. It's extremely close by.
So what do you do?
So for that, that's what I said. You tamponade the iris against the anterior capsule. You tamponade it, and that will cause compression forces at the periphery and block that blood. You just have to wait for some time. But the blood will not come from the angle. You will be noticing as you're increasing the intraocular chamber pressure, the blood doesn't come from the angle, but it comes from the pupil area. It comes from the pupil area, it keeps seeping in. And so when you increase the intraocular, make sure that you put Orogel, sodium hyaluronate, and tamponade the iris against the lens, anterior lens capsule. Whether it's a pseudophakic eye or a phakic eye, just push it against the anterior lens capsule and wait for some time, that will stop. But we have to leave some sodium hyaluronate in the eye, otherwise you get a supraciliary effusion very quickly. When that happens, you get angle closure very quickly.
Yeah, generally I feel around 30%.
And when they go home, they may present to other practitioners as a acute angle closure attack.
Right. Do you put them on pilocarpine for a month?
All patients we put on pilocarpine for 10 days after the surgery.
Thank you.
Sorry. Like in the case of malignant glaucoma, we know that ASO-CT you cannot pick up because it doesn't have a view behind. But do you see in all B scans pockets of aqueous to actually?
No, it's very difficult. You have to use high gain settings. You have to keep looking for it. So it's a clinical diagnosis only. We won't be able to confirm that, without aqueous power. But you could UVM. You can pick up ciliary body rotation, anterior rotation of the ciliary body.
Yes. That was a very interesting discussion. So I thank all the speakers for being here. I also thank KSOS for the wonderful opportunity. Thank you.